Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Statin drugs to lower cholesterol are a mainstay of preventing and treating heart disease. What are the benefits and risks of these medications? This is the People's Pharmacy with Terry and Joe Graydon.
Guidelines from the American Heart Association and the American College of Cardiology recommend statin drugs for nearly all older people and lots of younger ones. Have you been prescribed a drug like simvastatin or atorvastatin?
The balance between the benefits and risks of statins is controversial. Many people who start on a statin report side effects such as muscle pain. When do the problems overpower the advantages?
Coming up on the People's Pharmacy, two very different perspectives on the truth about statins and heart disease.
First, this news.
In the People's Pharmacy health headlines, taking antibiotics for just a few days might work just as well as taking them for a week or two, at least for some cases of pneumonia. For years, physicians commonly prescribed antibiotics for a week to 10 days. Patients were warned that if they stopped prematurely, the infection could return with a vengeance. A new study in JAMA Internal Medicine compared two regimens. Patients hospitalized with pneumonia took the antibiotic they were prescribed for at least 5 days. Those in the study group discontinued the drug after day 5 if they no longer had a fever or serious symptoms. The other group continued their antibiotic treatment for the full 10 days. There was no difference in outcome and no difference in length of stay in the hospital. Other studies have found that urinary tract infections also respond to shorter duration of treatment. It remains to be seen if other infections might benefit from the new mantra, shorter is better.
Space travel might be bad for the heart. 24 members of the Apollo space program flew into deep space between 1968 and 1972. 8 of them have since died, and more than 40% of those deaths were due to cardiovascular causes. Astronauts are well educated and have access to excellent health care, so it's a bit surprising that their cardiovascular mortality rate is 4 or 5 times higher than that of astronauts who did not get into space. The researchers who published these findings in scientific reports hypothesized that the Apollo mission's exposure to galactic cosmic radiation may be responsible for damage to the heart and blood vessels. Mice exposed to this type of radiation developed arterial damage. If NASA plans to send more astronauts to the moon and Mars, this problem will need to be solved.
Women going through menopause may tell you that it's giving them gray hair. 2 studies from UCLA now confirm that menopause, especially the night sweats and consequent sleeplessness that accompany it, contributes to more rapid biological aging. The studies used a biological clock to determine biological rather than chronological age. This tool looks at gene methylation in cells from blood, saliva, and the lining of the cheek. The investigators analyzed DNA from more than 3,000 women, including women participating in the Women's Health Initiative. They found that women who were younger when they reached menopause aged more rapidly. They also found that postmenopausal women who had 5 symptoms of insomnia were about 2 years older biologically than women of the same chronological age who were not having trouble sleeping. The scientists anticipate that they'll be able to use their biological clock technique to assess the value of menopause treatments such as hormone replacement therapy.
Another study found that women who reached natural menopause after age 50 had a much better chance of living into old age. The proportion of women living to 90 and beyond has been increasing in the U.S. A study of 16,000 participants in the Women's Health Initiative found that 55% of these women celebrated their 90th birthdays. Starting menstruation late, after age 12, was also associated with a longer lifespan. It may be that women who don't smoke and manage to avoid heart disease and diabetes are more likely to go through menopause later, or perhaps a longer productive span of 40 years or more has benefits of its own.
Cinnamon is a spice that makes apple pie tasty. Research in animals and humans suggests that it may help control blood sugar spikes after meals. Now, preliminary research indicates that mice that learn slowly can improve their performance if they get cinnamon in their chow. At the start of the study, the investigators were able to distinguish between quick learners that solved a maze problem in about a minute and slow learners that took more than twice as long. After a month of cinnamon-laced chow, the slow learners caught up. The scientists believe that this benefit is due to sodium benzoate, a breakdown product of cinnamon. This common compound stimulates the hippocampus, the memory center of the brain. It also improved the structural integrity of brain cells. Mice are not humans, and there's no clinical research to show whether people would learn faster if they spiced their food with cinnamon. Excess cinnamon consumption could put a strain on the liver. So we'll need to wait for more research to find out if cinnamon could boost human performance, as well as that of mice. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Heart disease remains our number one killer. For decades, we've been told that if we cut back on fat and lower our cholesterol, we could prevent a heart attack.
When it comes to lowering cholesterol, the standard is now a statin-type drug. Some health professionals have advocated that everyone over 50 should take such medication. Others say the benefits are really not as great as most people imagine. To find out the truth about statins and heart disease, we'll be talking today with two experts with widely different perspectives.
First, we turn to Dr. Steve Nissen. He's chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic and co-author of Heart 411, the only guide to heart health you'll ever need.
Welcome to the People's Pharmacy, Dr. Steve Nissen.
It's always good to be with you.
Thank you for joining us on the People's Pharmacy, Dr. Nissen. You know, the last time we talked, a couple of years ago, we were discussing the new guidelines from the American College of Cardiology and the American Heart Association, and everybody was going, oh, this is so great. The old goals, targets for HDL and LDL and total cholesterol, there wasn't enough science there anyway. We shouldn't have been doing that. This new approach, this risk calculator, this is great. But now people are beginning to question, is the risk calculator really that great? And some of your colleagues are even calling for people to go back to the old guidelines, the old targets of LDL under 100 or maybe even under 70 and total cholesterol under 200. So there's so much confusion. Can you just help us understand where we stand when it comes to heart health?
Well, I never thought that the new guidelines made any sense, and I was critical from day one for many reasons. The targets were very helpful to patients, and they were helpful to physicians. They gave us something to shoot for. I thought the evidence was pretty compelling that getting to a lower level of the bad cholesterol, the LDL cholesterol, was associated with a reduction in the risk of death, heart attack, and stroke, particularly in patients that have had a previous cardiovascular event. And I did not think the decision to abandon those targets was a wise decision. I was also critical, as were many other people, of the risk calculator. It's astonishing to me that national guidelines would be issued with a risk calculator that had never been published in the peer-reviewed scientific literature. The first time anybody got to see the risk calculator was when it appeared in a national guideline. And that can't make any sense because we need to have these things vetted by the scientific community before we use them widely. And so I think it is time to abandon these guidelines and go back to something like the older guidelines.
Now, what you're saying is that the risk calculator hasn't been thoroughly tested, published in peer-reviewed literature, presumably with studies showing that it makes sense, that it saves lives. But what about these guidelines? Do we have real data showing that if you get your LDL down below, 90, that it will save your life?
I think we have good data in some populations, but not in all. The data is most compelling in what we call secondary prevention. So if you've had a heart attack or a stroke or bypass surgery or a stent, there are really good data to show that lowering your LDL cholesterol is associated with a life-saving benefit. There was a study done, published in the very prominent medical journal, The Lancet, that pooled the data from all of these clinical trials. And these now involve more than 100,000 participants. And there was a consistent and very dramatic reduction in all of the things that we care about, morbidity and mortality, death, stroke, heart attack, in people who got their LDLs to lower levels rather than staying at higher levels. The evidence wasn't as compelling in people that have never had a cardiovascular event, but in those people in which risk was high, there was a very strong evidence that getting a cholesterol level down. What it's really about, what this is all about, is picking the right people to treat. We don't want the worried well taking statins. We want people that have substantial risk factors and a high enough risk, which is where the risk calculator comes in. And so having a good risk calculator to help us understand who will benefit and who will not benefit was fundamental to developing a good set of guidelines. What we ended up with was a risk calculator that wasn't well thought out. There have been some recent articles published where this new risk calculator was tested against populations where we knew actually what happened, and it performed very poorly. And so, unfortunately, we now have people adopting guidelines that have a risk calculator that simply isn't an accurate reflection of what the actual risk of having an event is likely to be.
Well, if our listeners were to go to the American College of Cardiology or the American Heart Association and put their numbers into that risk calculator, what we have found is that you could be a 63-year-old man, you could be a vegetarian, you could have no heart history, no heart attack, no stent, no chest pain, no family history of heart disease. You could run 10 miles a day. You could have a blood pressure of 120/80. You could have a cholesterol of 176, and you would still be advised by that risk calculator to take a statin. And ditto for women over 70. If you're a woman who's 70 with no problems, no events, no history, you would also be advised to take a statin. And we keep wondering, why is that persisting?
Well, that is a problem. And your observation is the same observation that I've made. There were a number of things about this new risk calculator that didn't make sense. It didn't include what is one of the most powerful risk factors that we know about, and that's family history. When we see patients, often they're men, but they can also be women, who have had everybody in their families had a heart attack or bypass surgery or a stent in their 40s. And we look at those people differently. Well, the risk calculator doesn't take into account family history. It also doesn't include a measurement of inflammation. We've known for some time that people with high levels of C-reactive protein, which is a blood test that shows us the amount of inflammation in the body, are at higher risk. And the risk calculator doesn't include anything about C-reactive protein. Now, it turns out there is another risk calculator, and I would encourage your listeners to try it out. If you type into a search engine, Reynolds risk calculator, spelled like the aluminum foil, Reynolds risk calculator, you'll get a risk calculator that includes family history and includes C-reactive protein, which is a measure of inflammation. And what has been shown now in some analyses is that the risks that you get using the Reynolds risk calculator are lower than the risks you get when you use the new ACC-AHA risk calculator. And those lower risks match pretty closely what we actually see in contemporary populations. And so you end up treating the right people rather than treating the wrong people.
Now, Dr. Nissen, when we talk about risk, we're talking really about sort of a statistical concept, aren't we?
We are. And the problem with risk calculators in general, and the problem in this whole area, is that you do end up having to treat a lot of people to prevent a modest number of events. I mean, a lot of the people that we end up treating will never have an event, whether they take a drug or not. And so it's a population-based approach. And I know that's hard for people to understand that, let's imagine that you have a population that has a risk per year of having a heart attack of, 1.5%. Well, it means that 98.5% of those people in the next year are not going to have a heart attack. And let's suppose that we can reduce that risk from 1.5% down to 1%. That means we've got to treat 200 people to prevent one heart attack. And that's hard for some people to swallow, that I'm going to give you a drug, and the chances are 199 out of 200 that you will not be one of those people that will benefit. But on the other hand, if you're that person who's destined to have a heart attack and we can prevent it, that's a lot of suffering that we can prevent. It used to be a harder decision when statins were expensive, but they're now generic. Some of them you can get a 3-month supply at a big box store for $10. And so it's not a cost issue. But there are downsides for sure to taking a statin.
That was exactly what I wanted to ask you about, because there are people who will say, well, if I'm that 1 in 200, I definitely want to be preventing the heart attack. There are a lot of other people who are going to say, I'd really rather take my chances and try other ways of lowering my risk because when I take statins, I have side effects.
Well, this is about shared decision-making. I believe that good physicians make decisions with their patients, not for their patients. And I can tell you that whenever I make a recommendation for a patient to take any drug, including statins, I have a discussion of risks, benefits, and alternatives.
You're listening to Dr. Steve Nissen. He's chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He's also co-author of Heart 411, the only guide to heart health you'll ever need.
We need to take a short break. When we come back, we'll find out about the risks of statins. How should you decide whether you should take such a drug?
Then we'll talk with Dr. David Diamond about the long-running cholesterol controversy. How did it get started?
We'll hear about the evidence connecting cholesterol and heart disease. How strong is it really?
We'll also discuss the difference between absolute and relative risk and find out why that matters.
When your doctor says you need to take a statin to save your life, how much longer can you expect to actually live?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339 online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show is number 1044. That number again, 800-732-2334, or visit our website, peoplespharmacy.com.
We're talking today about weighing the benefits and risks of statin-type cholesterol-lowering drugs. Who needs to take such medication?
We're talking with Dr. Steve Nissen, chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He's also co-author of Heart 411, the only guide to heart health you'll ever need.
Dr. Nissen, we've talked about the benefits of statin drugs. Can you tell us a bit about the risks?
There are some risks. Fortunately for statins, they are safe drugs, but they do have side effects. One of them is that probably about 5 or 10% of people will have muscle-related side effects, muscle pain or weakness. And sometimes that can make it very difficult to treat those patients. And, if you're one of those people, then you have trouble with these drugs, although many people do not. There is a slight uptick in blood sugar, meaning that a few more people who take statins are going to end up with a diagnosis of diabetes. Although, interestingly enough, the analyses of people whose blood sugar goes up a little bit when they take a statin seem to indicate that the benefits in preventing heart attack, stroke, and death persist, even though the blood sugar ticks up just a little bit. And so the benefits are still there, but it is not something that you obviously want to have. It's not desirable. But this idea of shared decision-making is critical in medicine. And I think that, we have to respect our patients. We have to listen to them. We have to tell them the truth about the positives and the negatives about drugs, which is frankly why your program is so popular and so helpful, because you do give both sides to the discussion. However, it is also important that we not throw the baby out with the bathwater. A heart attack is a terrible thing. Bypass surgery is no fun. I have to deal with this every single day. We have reduced the incidence of cardiovascular disease by about 50% over the last 2 decades. It is my belief that lowering of cholesterol levels with drugs like statins have played a key role in reducing the societal burden of heart disease. And so, as much as we want to say to people, don't want you to take a drug if you don't need it, we also want to say to people there are real benefits to individuals as well as to the society in general in making sure that we identify people with high cholesterol and treat them appropriately.
Dr. Steve Nissen, in summing up your career and your perspective on how people can reduce their risk of having a heart attack, besides the obvious, stop smoking, eat a healthy diet, and exercise, what is the take-home message today on the People's Pharmacy when it comes to protecting your heart?
The most important thing, there's only one risk factor that you can't alter, and that's you can't pick your parents. Your genetic history, family history, you can't change. Everything else you can change. Your body weight, your exercise patterns, your cholesterol level, what you eat, all of those things are within your control. And I will take you back to the year 1900 when we lived a different lifestyle. Coronary heart disease was not one of the leading causes of death in America. It was other disorders like pneumonia and tuberculosis and other things. And this is a disease of contemporary American lifestyle. And the one thing we didn't talk about today so much that I just really want to emphasize is that there is an incredibly powerful drug that everybody has access to, and you don't have to take a pill to use it. It's called exercise. The evidence on people who exercise regularly, vigorous exercise, 20, 30 minutes a day if possible, is as much as a 30 to 40% reduction in the age-adjusted mortality rate or risk of heart attack and stroke. And there are no side effects. You feel better. Your cognition is better. You will live longer. If people would just take the time to do that, they can stay healthy for a long period of time. And I would really urge your listeners to adopt a healthy lifestyle. Now, we need to get it right in terms of telling people what a healthy lifestyle looks like. It doesn't look like an ultra-low-fat diet. It looks like a Mediterranean diet, lots of exercise, controlling blood pressure and cholesterol. And if you do those things, you can ward off heart disease for a very long time.
Dr. Steve Nissen, thank you so much for talking with us on the People's Pharmacy today.
It's been a pleasure, as always.
You've been listening to Dr. Steve Nissen, chair of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He's co-author with Dr. Mark Gilinoff of Heart 411. Dr. Nissen is one of the country's foremost cardiologists.
For a somewhat different perspective on statins and heart disease, we turn now to Dr. David Diamond. He's professor in the departments of psychology and molecular pharmacology and physiology at the University of South Florida. He's director of the Center for Preclinical and Clinical Research on PTSD at USF and also directs the USF Neuroscience Collaborative. Dr. Diamond is a research career scientist at the J.A. Haley Veterans Hospital.
Welcome to the People's Pharmacy, Dr. Diamond.
Thank you for inviting me.
Dr. Diamond, we have been, I guess one could say, fighting the cholesterol wars for decades. There is a group of people, scientists, clinicians, who basically say, look, serum cholesterol, it causes heart disease. Just get cholesterol down and, you've got things under control. There's another group that basically says, wait just 1 minute. It's a lot more complicated than that. Cholesterol is vital for every cell in the body. Without it, we couldn't function. How did you get interested in this controversy, and what have you found?
Well, I actually got interested in this about 10 to 15 years ago because I had abnormal cholesterol levels myself. And my doctor actually said to me that I was at high risk for developing a heart attack. And my basic expertise is in brain function, not in heart disease. And so I was very concerned because my cholesterol numbers were quite extreme. I had extremely high triglycerides and very low of what they call the good cholesterol. And that combination is considered to be very unhealthy. And so I was very tempted when my doctor urged me to take a statin to actually take the medication because it's very disconcerting to get that kind of recommendation from a doctor. But instead, I decided I should learn for myself about whether or not cholesterol actually does cause heart disease and whether the statins would be effective in reducing my risk for developing a heart attack.
So how did you go about this? And does cholesterol really cause heart disease?
Well, I decided just to read a few papers, and I truly went into this with an open mind. I started with a few papers, and frankly, I was astounded at what I read, and a few papers then led to a few thousand papers, as well as dozens of books on the topic. And one epiphany after another, frankly, led me to realize that there's been quite a bit of deception in this area of research, that it's very clear that cholesterol itself does not cause heart disease, and it's only peripherally related to heart disease, and that cholesterol is actually used by tissue to repair itself when it is damaged. And there's very little evidence of cholesterol actually being involved in development of heart disease.
Well, let's go back to Ancel Keys, because he was, after all, I think, the first scientist, or certainly one of the key ones, in sort of proposing that cholesterol was the problem. And perhaps you can tell us a little bit about his background, what he found, and perhaps what he ignored.
Well, what's really unfortunate is that Ancel Keys just had a bias, first of all, against fat in the diet, and then specifically saturated fat, which you find in animal fat in high degree. And he asserted that when you eat saturated fat, it will raise your blood cholesterol. If you raise your blood cholesterol, somehow that will then cause you to have a heart attack. And Ancel Keys had no expertise whatsoever in nutrition or heart disease. And in fact, he was completely wrong about much of his assertions.
Well, it makes so much sense that if you eat saturated fat, it'll, clog your arteries. But what was his background?
Well, actually, as I recall, he had a bachelor's degree in economics and a PhD in something related to marine science. And he, in fact, studied fish physiology for decades. And frankly, it was only because Ansel Keys published a paper in 1953 in which he showed a relation between fat in the diet and heart disease that anyone paid any attention to him. And in fact, it turned out this was fabricated. He created that relation by selecting data that made it appear as if there was an association between fat in the diet and heart disease. In fact, later work that became much more refined has clearly shown, in fact, as now the news is out lately, that fat in the diet is not associated with heart disease. And specifically, in fact, people who eat more saturated fat, in fact, you find association, have less heart disease. And in particular, the country that represents this best is France. People in France have one of the highest percentages of saturated fat in their diet in the world, and perhaps the highest rate of overall fat in their diet, and yet they have an extremely low rate of heart disease as well as obesity.
Now, the American Heart Association and the American College of Cardiology have staked their flag in the saturated fat is a bad thing and LDL cholesterol causes heart attacks perspective. And if you go to their risk calculator, which came out a couple of years ago, you discover that pretty much every man in America over the age of 63, regardless of blood pressure, regardless of diet, regardless of exercise activities, regardless of anything, they will recommend that that person, that man, needs to be on a statin. And just about every woman age 70 and above, regardless of any other risk factors, needs to be on a statin. And they're pretty adamant that, the discussion is over. The controversy is done. Statins are pretty much essential for older people. What's your take on that?
Well, that is basically the gist of the paper that Dr. Ravenskov and I wrote, basically to try to dispel that myth that statins, first of all, are all that effective, which they're not at reducing incidence of heart disease, nor are they necessary. The remarkable thing is how incredibly ineffective statins are at actually making any difference in the incidence of coronary events or at enabling people to live longer. This is the deception that we put right in our title and we discussed throughout our paper, that the actual difference in the incidence of coronary events, whether you're looking at heart attacks or strokes, is really trivial. And frankly, we are the only ones that are emphasizing it is minuscule. If you compare placebo-treated patients with the drug-treated patients, there's almost no difference in the incidence of coronary events.
Now, Dr. Diamond, at one point, Lipitor was advertising that it reduced heart attacks by a third. And you're saying not so fast. That's not the way to understand it. Now, I imagine that the drug company was using the relative risk because it looks much better. But can you help us understand the difference between relative risk and the absolute risk you're talking about?
It's such a great question to ask because most people, doctors included, don't really understand what that reduction of risk means. When you say Lipitor reduces the risk of a heart attack by 36%, which is in that ad for Lipitor, people think that overall I'm a third less likely to have a heart attack and that a third of all patients who take Lipitor won't have a heart attack. And that's not the case at all. If you actually look at the real numbers, okay, in that study, for example, when you look at people at risk for having a heart attack, about 97% who were given the placebo, which means no treatment, did not have a heart attack. And so when you look at the people who took the Lipitor, about 98% of the people did not have a heart attack. And so that's why I say the difference is really very small. The difference is only 1 out of 100 people will have one less heart attack, and that's in about 3 years. So how do you come up with a third? How do you come up with this 36%? Well, that's where you have this relative risk reduction, which is you take the 97%, and the difference between 97 and 98 is 1%, And you're allowed then to divide the 1% by the rate of heart attacks in the placebo group, which is 3%, the difference between 197. So you take that difference, 1, and you divide it by 3, and you get about a third. That's a 33% difference. So you see, this is a way to use statistics to dramatically inflate the appearance that the drugs are having a dramatic effect. When again, I really think it's important to understand when you go to your doctor and you say, how less likely am I to have a heart attack when I'm on the Lipitor, the doctor really should tell you, well, for every 100 patients compared to placebo, there's a difference in only one patient. And for 99 of those 100 patients, there will be no difference whatsoever. That's what that 33% reduction in heart attacks means.
Dr. Diamond, there was a study just recently published in the journal BMJ Open from some Danish researchers that looked at something for the very first time, and that was the what we'll call longevity effect. How much longer do you live if you take a statin compared to a placebo? So they were actually looking at randomized controlled trials. And they were looking at what they call primary prevention trials where, otherwise healthy people were taking a statin or a placebo. And then they also looked at secondary prevention trials. This is where someone has already had a heart attack or has diagnosed heart disease and how that worked. Can you give us some sense of what they discovered?
Yeah, this was a very thorough and extensive study of many of the statin trials. And the findings are consistent actually with even the prior research before the statins were around. There are other drugs that can reduce cholesterol as well. And overall, essentially there's no difference in longevity. They actually came up with a calculation of a matter of days that you'll actually overall live about 3 to 5 days longer if you're on a statin, which of course gets lost in the noise, meaning there is no improvement in longevity when one takes a statin. So I think it's very important that people understand there is no evidence that they will live longer and trivial incidence of any change in actual heart attack events.
You're listening to Dr. David Diamond, professor in the departments of psychology and molecular pharmacology and physiology at the University of South Florida. He's director of the Center for Preclinical and Clinical Research on PTSD at USF and also directs the USF Neuroscience Collaborative. Dr. Diamond is a research career scientist at the J.A. Haley Veterans Hospital.
It is time for a short break. After that, we'll find out why Dr. Diamond is concerned about drugs that are considered extremely safe.
The recommendation is that everyone with diabetes should be on a statin, even though statins raise blood sugar. We'll explore that idea in greater depth.
We've heard that higher cholesterol may be beneficial for older people, yet every man over 65 and every woman over 70 has been told to take a statin regardless of other risk factors. We'll get Dr. Diamond's views.
We'll also find out if we're getting our money's worth for the millions we spent on statins.
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. The number's 800-345-7339. The website is uttercream.com.
If you'd like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1044. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
Statins are one of the most successful classes of medications in the history of the pharmaceutical industry. Over $100 billion has been spent on such drugs as Lipitor, Crestor, Zocor, and Livalo. Have we gotten our money's worth?
We're talking with Dr. David Diamond. He's professor in the departments of psychology and molecular pharmacology and physiology at the University of South Florida. He's director of the Center for Preclinical and Clinical Research on PTSD at USF, and also he directs the USF Neuroscience Collaborative. Dr. Diamond is a research career scientist at the J.A. Haley Veterans Hospital.
Now, a lot of cardiologists will say, well, but these drugs are so safe. And they have anti-inflammatory activity as well as the cholesterol-lowering effect. So, what's the harm? These drugs really, could prevent a secondary event for somebody who has already had a heart attack. No side effects. It's all good.
Well, certainly a 1% over improvement in coronary events in a very large population actually would be great. If the statins had that beneficial effect, no matter how small, without any side effects, it would be a fine drug. But the side effects are really extensive. The statins have quite a bit as far as side effects, which we could talk about for a long time. But one of the primary effects actually is the deterioration of muscles and joints, the myelitis that develops, and that actually results in potentially damage then to kidney function because you've got the excess proteins floating around as a result of damage to muscles. But what's really been characterized very thoroughly in the last few years is an increase in type 2 diabetes that results in people taking statins, and it's not trivial. Recent work out of Scandinavia in which you've actually looked at people taking statins, you follow them for about 6 years, and you find a near doubling in the rate of type 2 diabetes in the people taking statins compared to placebo. And here again, doubling is relative risk. I should actually emphasize that.
I was just going to ask you that.
Sure. When I use relative risk, I think it's also important to use the real data, which would be the absolute risk. And so if you just find people at risk for heart disease tend to be overweight, tend to develop diabetes, and you find that people given the placebo, about 6% of those people develop type 2 diabetes. But the people taking statins, almost 12% of those people develop diabetes. So that's not a trivial difference. So you're when I say doubling here, you're looking at from 6%, almost a doubling in the risk of diabetes.
But wait a minute, Dr. Diamond. The American College of Cardiology and the American Heart Association says everyone with diabetes must be on a statin. So the implication is that statins are really good for people with diabetes.
Yeah, that absolutely makes no sense to me at all because, in fact, if you have someone already at risk and developing diabetes, about the last thing you would want to do is give that person a drug that would even promote further development and exacerbation of diabetes because potentially what the statins are doing is interfering with insulin sensitivity in the pancreatic cells from functioning properly. And so you've already have someone at risk, and now you're even increasing the likelihood they'll have further pancreatic damage.
Dr. Diamond, if high cholesterol, is not the cause of heart disease, do we have any idea what is?
Well, and again, I want to emphasize something that people aren't aware of. Almost half of people right now over the age of 60 are taking a statin, such as Lipitor or Crestor. And what people really need to understand is that people in that age range, over 60, in fact, people with high cholesterol are healthier. And it's been shown statistically people will live longer with high cholesterol compared to low cholesterol. So people with high cholesterol are much less likely, for example, to develop cancer compared to people with low cholesterol, as well as coronary events. You actually see fewer coronary events in people with high cholesterol who are older, over 65, 75. People are much healthier if they have high cholesterol compared to low cholesterol. So that's another reason not to be lowering your cholesterol for an older person. Now, the other really important thing that maybe doesn't make sense to your listeners is if cholesterol is blocking your arteries, then how can it be that you actually live to a very long, ripe old age with very high cholesterol? And the reason for that is because cholesterol does not block arteries. It doesn't damage arteries. And so people of the elderly age, people beyond 60 and 70, with high cholesterol are actually healthier. So it doesn't fit at all with the idea that cholesterol is damaging arteries.
Dr. Diamond, if a listener wanted to follow up on that research you just mentioned, which I think is going to be news to a lot of folks, that higher cholesterol is healthier for older people, where would they look?
Well, the first thing is it's in the peer-reviewed medical literature. There are at least a dozen studies published in well-respected medical journals, including the Lancet and British Medical Journal, following people for 10, 20, 30 years. And you get a blood sample, see their cholesterol levels, and you find 30 years later the people who had the lowest cholesterol are much more likely to be dead compared to the people with the highest cholesterol. So the first thing is all it takes is a search of the medical literature and you find it. I am actually in the process of writing a review paper with my collaborator, Dr. Ravenscoff, in which we'll review this literature. But I can tell you it's been around for decades. It just needs to be promoted to the general public.
Most patients, physicians, especially cardiologists who are listening to us right now, are shaking their head in astonishment because this idea that older people might do better with higher cholesterol is so counterintuitive. We've been told for so long that cholesterol is the problem, not the solution. I just wonder about how you would respond to so many of the messages we get from women in their 70s, sometimes in their 80s, and even in their 90s who say, my doctor insists I must be on a statin. My total cholesterol is 240 or 260. My HDL cholesterol is 80 or 90. And he wants me to get my LDL cholesterol, the bad stuff, down below 100. And the only way I can do that is by taking fill in the blank, atorvastatin, simvastatin, pravastatin, rosuvastatin, one of the statins, but it makes my muscles sore. It makes it harder for me to exercise and do the activities that I love. What do you respond to that woman? Because we have received so many messages like that, we don't quite know what to say.
I have heard so many people say that very same thing, that they tell their doctor that they've developed muscle pain, joint soreness, other effects, as well as cognitive impairments. And the doctor says, well, what would you rather have, muscle pain or heart attack? And so they accept that they'll have the muscle pain because they think they become immune to developing heart disease. And that just simply is not supported by the actual studies. But I should also emphasize that cholesterol itself has really never been well associated with heart disease. And so you've had to actually look at these different components. In fact, you have one component in which the cholesterol is packaged in the HDL. And the higher that is, the more healthy people are. The LDL, again, the problem is being associated with disease does not mean that it causes disease. LDL, actually it's called the bad cholesterol, is actually a part of the immune system. LDL works with white blood cells actually to kill bacteria and to neutralize viruses, which is in part why you find LDL inside the plaque, because it's actually been used to kill bacteria that are promoting inflammation in the artery wall.
So are those bacteria the true culprit behind heart disease?
There is good evidence that infection is a significant part of heart disease. What you actually have in setting up for heart disease is basically a person as a result of insufficient diet, which let's say is insufficient vitamin K2, which you will find in egg yolks and full-fat cheese. And it's an incredibly important vitamin which actually directs calcium into your bones. So just by taking a calcium supplement, that calcium actually ends up in your arteries if you don't have enough vitamin K2. And here is the irony, is that actually when you have full-fat cheese and egg yolks, you end up directing that calcium into your bones rather than your arteries. And when the calcium ends up in your arteries, as well as when you have high blood pressure, you strain those arteries, and there are tiny little arteries called the vasa vasorum, and these are all around the walls of the heart arteries. And when you clog up those arteries because of high blood pressure, there's a local hypoxia, which means that tissue doesn't get enough oxygen. That tissue actually dies. That's actually inside the artery wall dies. And when that tissue dies, it's then susceptible to infection. And so you have infection, which is actually inside the walls of your artery. That's actually where you find the plaque develop, not in what's called the lumen where the blood flows, but it's inside the wall gets damaged first. And then that swells because you have cholesterol that comes in to be able to repair the tissue and to kill the bacteria. And as that wall swells from repeatedly having high blood pressure, damage to your artery wall, the wall swells until eventually it can choke off the artery. And then ultimately the coup de grace is that not only do you have high blood pressure causing damage, but that stress that people have without sufficient exercise literally causes our blood to clot. And so when our blood clots, it can then block off the artery. And that has nothing to do with cholesterol.
Dr. Diamond, we have mentioned a few of the side effects associated with statins. For example, there was some discussion of the muscle pain that people experience, and sometimes people complain of joint pain. What about cognitive function? What about nerve pain? What about sexual dysfunction? Are there any other side effects that people need to be aware of? Peripheral neuropathy, for example?
Yeah, the peripheral neuropathy is really quite common. It's been described extensively in the literature. I think it's important also to recognize the brain needs cholesterol to function properly. The brain uses cholesterol to produce new brain cells. Every day we have what's called neurogenesis, in which you have new brain cells that are formed that are very important for memory formation. And there are studies clearly linking the use of statins to impaired cognition. In fact, my colleagues and I published a paper showing that when one looks at adverse cognitive events, you see a clear relation to the capacity of the statin to be able to gain access to the brain. And by that, I mean there's a blood-brain barrier that stops many substances from being able to get into the brain. And some statins are much more effective at getting into the brain. And those statins are the one you see far greater incidence of cognitive adverse events, such as Lipitor is one example.
Dr. Diamond, a lot of people are concerned about these side effects. But doctors say the studies show that statins save lives. Do people have any other option if they're concerned about possible side effects?
These studies always involve a comparison of statin to routine or conventional treatment. And that is where you see a trivial benefit. There are so many studies showing that one can have cardiovascular benefit by a change in diet and lifestyle. And I don't mean the kind recommended by the American Heart Association. Consuming more dark chocolate, for example, and more butter and more eggs actually all improve blood pressure and the lipid profiles. And so I think actually a fantastic study, which will never be done, is to compare having one group eating more butter and more full-fat cheese and more dark chocolate compared to a statin. And I believe the difference really would be dramatic as far as the improvement being far superior for the diet-induced changes compared to just taking a statin.
Oh, I think you'd find a lot of people who would be willing to volunteer for the, dietary arm of that study.
Yes, I think so.
Dr. Diamond, how much money has been spent on statins over the last couple of decades, and have we gotten our money's worth?
Well, I don't know how much has been spent, but the other way to turn this question around is what are the revenues from statins? So perhaps that's what you mean. The estimate is that the pharmaceutical companies have been able to benefit from over $150 billion. It's with a B, in revenue from the statins. And Crestor alone now is moving up the scale against Lipitor, and just this year is expected to earn over $7 billion in revenue. So there's a tremendous revenue that's been generated by statins. And given that you've already stated the finding on mortality, these people are not living longer, and any benefit from reduction of heart disease is trivial.
Dr. Diamond, what is the message for our listeners today when it comes to both diet as well as medications to control cholesterol?
Well, what I try to emphasize to people is that good health is not found in a pill. As appealing as it sounds, we would like to believe that you take a pill and then you're immune to a disease, whether it's heart disease or any other. It's really quite simple. I think if you want to be healthy, it's important to get some exercise in your routine. The great thing about exercise is that it'll clear your blood of those clots. It'll actually improve the functioning of your cardiovascular system. And so exercise is important. I also do not agree with the American Heart Association that emphasizes a low-fat, low-cholesterol diet. I think it's very important to dramatically reduce the carbohydrates in your diet. That is, any food that'll dramatically raise blood sugar. That ultimately contributes to heart disease as well as other diseases such as cancer. So reducing the simple sugars in your life, reducing bread consumption is very important. Controlling stress, very important, because stress actually exacerbates other diseases. So I look at these very simple lifestyle changes that really overall will help someone's cardiovascular system as well as resistance to other diseases, and not to seek the answer from taking a pill.
Dr. David Diamond, thank you very much for talking with us on the People's Pharmacy today.
You're welcome. It's been a pleasure.
You've been listening to Dr. David Diamond. He's professor in the departments of psychology and molecular pharmacology and physiology at the University of South Florida. He's director of the Center for Preclinical and Clinical Research on PTSD at USF and also directs the USF Neuroscience Collaborative. Dr. Diamond is a research career scientist at the J.A. Haley Veterans Hospital.
We spoke earlier with Dr. Steve Nissen, chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic.
You've just heard from two experts with very different views on cholesterol-lowering medications. We suggest you follow Dr. Nissen's advice regarding shared decision-making with your doctor. Make sure you have a frank discussion about whether a statin drug is right for you. If you have heart disease or have had a heart attack, it may be appropriate to consider a statin. But if you have high cholesterol and are otherwise healthy, you might want to talk with your doctor about what diet and lifestyle choices you can make to keep your heart healthy.
A Mediterranean-style diet with healthy fats and a good exercise regimen will do your heart good no matter what your situation. That's something both our guests seem to agree on.
Lynn Siegel produced today's show. Al Wadarsky and David Tripp are the engineers. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1044. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show and your personal experience with statin-type cholesterol-lowering drugs.
At our website, you can sign up for our free online newsletter or the free podcast of the show. You could listen at your own convenience or share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
When it comes to Father's Day, dads want steak. And the experts at Omaha Steaks are making it easy for you to deliver uncompromising quality with gifts that are sure to make his day. Plus, get an extra $35 off with code THANKSDAD when you shop at omahasteaks.com today. But don't wait. Father's Day is June 15th. Shop now at omahasteaks.com and get an extra $35 off with code THANKSDAD. Minimum purchase may apply. See site for details.